This is the 8th Roche Record report in the continuing series, Psychiatric Consultations. The theme, Emotional Problems in Women. Discussion centers on the interrelationship of gynecologic and psychologic disorders, which often attend menstruation, pregnancy, and menopause. Two noted Canadian specialists are queried by Dr. Marjorie L. Smith, a general practitioner in Halifax. Dr. Harold B. Attlee is Professor Emeritus of Obstetrics and Gynecology at Dalhousie University. He is also on the attending staff of Grace Maternity and Victoria General Hospitals, Halifax. Dr. Robert J. Weil is President of the Canadian Psychiatric Association and Associate Professor of Psychiatry at Dalhousie University.
There are 3 periods of a woman's life when psychological problems are likely to arise, and it is with these that we propose to deal. The 3 periods are the onset of menstruation, pregnancy, and the menopause. I will start first by asking Dr. Weil, what is the best advice to give a girl prior to menstruation?
What I would tell a young girl is this. Menstruation is a normal process which recurs in regular and in the beginning of the menstruation at times irregular intervals. It represents simply the preparation for pregnancy, which, if it has not taken place, is cast away. It is nothing more than that. I would try to dispel all the myths and misconceptions which exist about the menstruation, such as the idea that it represents a riddance of some poison in the body, or that it is a curse, etc. I would emphasize that menstruation should not jeopardize any normal activity of the girl. I would permit and in fact encourage and stimulate the girl to ask any question she would like, which I then would answer in a relaxed and factual manner in order to allay her anxiety regarding this normal function of woman.
As family physicians, in recent years, many of us are getting involved in the sex education problem. I feel very strongly that it is important for the girl to be taught something of the anatomy and physiology of her makeup, with the use of diagrams, moving pictures, or what have you, but always emphasizing the normality of this process. Dr. Attlee, would you like to add to this subject?
Perhaps I would like to emphasize the point that Dr. Weil brought out, that in menstruating a girl gets rid of nothing except a breakdown of something that was built up, and that there's nothing poisonous or abnormal in it. And then I think perhaps I would explain to the girl or mother that in the first year or two she may miss a period or two which may alarm them, but that after a couple of years things settle down to a more or less normal rhythm. The amount of the flow tends to increase, and everything goes along as it should.
Dr. Weil, in general practice, very frequently we run into a patient who is complaining of disabling pain associated with her menstrual periods. What is the psychiatrist's viewpoint on this subject?
First of all, it is a problem of pain. Pain is a very subjective response to all kinds of stimulations, and this response depends upon the pain tolerance of the girl, anxiety that is present, the tension, and very often the fearful anticipation of the subject. The location of the pains may have a significant and at times anxiety-producing meaning, particularly when the pain is located in the girl's pelvis. Reduction of anxiety goes at times a long way to alleviate pain sensation in a dysmenorrheic woman. As a psychiatrist, I would suggest that anxiety should be reduced by all means. First of all, with medications such as mild tranquilizer or analgesics. Secondly, by sitting down with this girl or woman and elicit from her some conflicts which may exist in her present life situation, or which may have been the hangovers from the past, some conflicts she may have had about sex, menstruation, etc. Certainly, I would explain to her the function of the genitourinary tract. I was surprised in our research on abortion how little women really know about the function of their sex organs. Then I would give her reassurance. And if the preceding therapeutic methods fail in the absence of organic disease, then I would advise psychiatric consultations and possibly also psychiatric treatment. But maybe Dr. Attlee would have more to contribute from his point of view.
Well, I agree with Dr. Weil about trying to discover whether or not there's been any serious psychological factor in the girl's life in the immediate months prior to the onset of menstruation. Very often one finds in girls who've been going along perfectly normally and then suddenly they begin to have pain that there has been a good deal of conflict going on in their life and that this probably plays a fairly large part. The other thing is, in the usual case, to try various tricks that seem to help some girls. One girl, for instance, will find that if she takes exercise, violent exercise, enough to produce a sweat for the 3 or 4 days before menstruation sets in, that it helps her. Another girl will find that if she gets into a very hot bath at the very onset of the pains, that will give her relief. Then, of course, we know about aspirin. Probably of the 10 tons of aspirin that was imbibed on this continent today, 9 of it was taken for painful dysmenorrhea. But when aspirin is unable to affect the pain, none of these other things really get at it. I think that the next step, at least the next step that I've always taken of late years, was to put them on an estrogenic hormone. And I think probably one of the more sophisticated modern hormones might work equally well, though perhaps more expensively. That should take care of most of the dysmenorrhea. I don't think there is a place there used to be for such treatment as dilatation of the cervix and curating of the uterus. I think those things would be very, very last resources.
And Dr. Attlee, would you agree that this disabling pain sometimes or often disappears with marriage?
Pregnancy is one of the best cures for dysmenorrhea, but we don't advise it for the unmarried.
Dr. Attlee, one problem we see quite frequently is the very worried mother, upset because her daughter of 15 has not begun to menstruate.
Well, in these days of teenage fornication, perhaps these mothers have some cause to worry, but I think that by and large, if a girl has never menstruated, she's probably not pregnant, and that therefore she's just simply having delayed menstruation. So to these worried mothers, I say, well, relax and give it 2 or 3 more years and see what happens. Let's wait till she's 17 or 18. In some cases, menstruation is delayed that long.
Would you like to comment on what age you would investigate a patient for an organic cause for amenorrhea?
Well, I think I would investigate the girl when her mother first brings her as well as I possibly could to make sure that there wasn't anything organic. Perhaps a better question is, what age would you start to do something if the patient hadn't menstruated? I have interfered and tried to play God in some of these cases and have created a situation far worse than the one that was brought to me, because while one could start menstruation by giving hormones, you stopped the hormones and the menstruation ceased, which created a great deal of dismay in the family. So my policy tended to become, well, let's wait till the necessity, the vital necessity arises. Not let's wait till this girl gets married and she doesn't have any family. And then is the time, I think, to start the treatment.
Before we leave this topic of menstruation, Dr. Weil, what place do you feel psychiatry has in menstrual disorders?
Now, menstruations can be painful, they can be absent, irregular or bleeding may be abnormal. All of these abnormalities can have psychophysiological origin. Disturbance of the cortical, hypothalamic, pituitary and ovarian axis may be responsible for menstrual abnormalities. May I mention, for instance, a girl who becomes amenorrheic out of fear that she may be pregnant, or the young woman whose dysmenorrhea disappears when away from home. And teenage girls who bleed excessively after an emotional trauma. I'm sure in general practice you see this kind of cases fairly often. I understand from my gynecological and obstetrical friends that more unpregnant uteri are curetted than pregnant uteri. Menstrual disorders occur not infrequently in girls with emotional disorders. The anxious, the depressed, the immature, and the psychotic girl may have problems with their menstruation. Therefore, I would suggest in such cases a psychiatric history and a mental status examination should be elicited. What I'm trying to say is that the important thing in these cases is very often to treat the girl and not her localized complaints. However, if a suspicion exists that symptoms of dysmenorrhea may be a part of a more serious psychiatric illness, again, psychiatric consultation should be thought.
Well, I don't want to disagree, but I want to introduce an answer to a question Dr. Smith tended to raise about examining these unmarried girls. Is it a good thing to do or not? Well, I think that if a girl has amenorrhea and is having pain, she should be examined to make sure she hasn't got a blockage of the hymen. I think if she's bleeding irregularly, the cervix should be looked at and a Papa-Nicolau test taken. Now, for the rest, I think that you can learn just as much from a rectal examination about the state of the pelvic organs as you can by a vaginal examination. So few people realize that, but I think that most practicing gynecologists will agree that in some cases they learn actually more by rectal examination than they do by vaginal. I just want to emphasize that point.
Thank you, Dr. Atlee. Well, we'll now pass on to the problems connected with marriage and pregnancy. Dr. Atlee, I'd like to ask you this question. What should one tell the girl who comes to her family doctor on the eve of marriage for advice?
You mean for advice as to what's likely to happen to her within the next 2 or 3 weeks?
Yes.
Well, I try to explain the situation as casually as I can. I don't think one should say to a girl, well, this is all going to be ecstasy, because I think most girls do have a certain amount of pain with their first coitus. So one of the most valuable pieces of advice I think you can give a girl is to pack away a tube of Vaseline in her traveling case and to get her husband to use this quite freely for the first 2 or 3 nights. Now, I think she should be also told that if there's difficulty, unsurmountable difficulty, or if after, say, 2 or 3 weeks she continues to have pain, that she should be examined to see if there is some physical cause for this. Apart from that, I don't know that there's anything very much that I can tell her. She may want information on birth control, and a good many of them ask that. But these days, most girls know about the pill, and that there really is not very much of a problem there.
And you don't feel, Dr. Atlee, a pelvic examination at that time is essential?
Well, they're in your office, and I usually examine them just as part of the routine. But I can't say I've ever found anything that I thought was significant in all the examinations that I've done. But I suppose if I'd kept it on for another 100 years, I might have counted it.
May I say something here that one should tell a girl that's about to get married also a little more about her coexistence with a man, and that her relationship outside of bed may determine greatly what goes on at night. Again, I would ask her what particular question she has and try to clarify some of her anticipations and fearful anticipations and reassure her.
In other words, you would try to get her to relax and to discuss all her worries and about the forthcoming days.
Correct.
Then I think another thing could be a cause of worry, and is a cause of worry, is that the girl fails to get the orgasm, and she comes to a doctor and feels badly about this. Well, I think that a newly married girl can be told that that's something that usually adjusts itself. It may take a little time, but it usually adjusts itself, given lots of opportunity.
Along those lines, Dr. Atlee, I'm going to ask Dr. Weil. While we do not encounter it as often as we did, frigidity in one form or another is a difficult problem to deal with. What do you suggest?
Frigidity represents a group of sexual disturbances which are associated with a lack of orgasm during sex play and/or intercourse. Some women suffer from a complete anesthesia of the genital area. They may be difficult to arouse sexually. Others again can be aroused, but orgasms cannot be achieved. Pains, for whatever reason, may prevent orgasm. And finally, there are women who reject any sexual approaches in a rather phobic, fearful, irrational manner. Again, it may be anxiety which is responsible for unsatisfactory sexual experiences. Therefore, the main treatment should consist of alleviation of this anxiety, encouragement of the discussion of the woman's present and past conflicts and problems, particularly in the area of sex. Again, explanation of the sexual function, reassurance, and very often I found that interviews with the patient's husband may be of benefit because he may be responsible for his wife's lack of orgastic enjoyment. Many husbands approach their wife in a manner that induces resistance and disgust. Intercourse is only one mode of communication between spouses, and if there are conflicts between them outside of their bedroom, it is understandable that these conflicts will be carried over into their sexual activities. The resistant cases, the phobic cases I spoke about, especially those who refuse even the slightest approaches, they should be referred to a psychiatrist. And I must admit that even we have a great deal of difficulties in dealing with these cases. Behavior therapy seems to work in the hand of those who have experience in it.
Dr. Atlee, would you have any further comments on this?
Well, there's really very little that I know that a gynecologist can do for the frigid or semi-frigid woman. As far as the actually totally frigid woman is concerned, I believe that she's entirely a psychiatric problem. The other woman, the woman who likes to go to bed with a man, who gets a certain amount of enjoyment and who really wants to get the orgasm, which would give her, say, a complete unfrigidity, is a fairly common occurrence. And I think certain advice can be given her that might be useful. What I say to them is, don't try too hard. Happiness is a thing, or ecstasy is a thing, that the harder you try for it, the more it eludes you. So the best thing is to simply relax. And perhaps it's more apt to come to you that way than if you really try too hard for it. And the other thing you can do, which will make the thing more satisfactory for the husband, and therefore maybe a slightly more cohering thing as far as the marriage is concerned, is if after a time you find that you still don't get the orgasm, to let on that you do. Now, I have been taken to task by psychiatrists for giving this advice, but I've known women who have taken it and who said that it did make a great deal of difference to their husbands, because husbands have a feeling that if a woman doesn't get the orgasm, there's something wrong with their potency, and it bothers them. So that if you can offset that thing by a little bit of harmless kidding, keeps the man feeling that he's still potent, and to that extent perhaps may save a marriage from going on the rocks.
Pregnancy has many psychological implications. Dr. Weil, could you say a few words on this subject?
Pregnancy is a concept that means as women think of it, and in reality conveys all kinds of meanings to a woman, from intense fear to a sense of self-fulfillment. Misconceptions about pregnancy, rejection of the feminine role, and again anxiety and fearful anticipations can cause or can contribute to all kinds of complications of pregnancies and childbirth. Minor complaints such as fatigue, drowsiness, overeating, a variety of pains in different parts of the body are frequently signs of emotional difficulties in the pregnant woman. The more specific complications of pregnancy is nausea, vomiting, and threatened and spontaneous and habitual abortion may all be associated with psychological problems.
On the subject of spontaneous abortion, Dr. Weil, do you feel it's a psychiatric problem?
It is not alone a psychiatric problem, but psychological factors play a role. At Dalhousie, a multidisciplinary team has studied spontaneous and habitual abortion, and we have demonstrated that psychological factors are definitely involved in their genesis. I will very briefly hit the high points of our findings. Personality difficulties occur more frequently in aborters than in non-aborters. Signs of immaturity or compulsivity are not infrequent. Secondly, communication difficulty between the spontaneous aborter and her spouse, especially on the emotional level, in the face of apparent good relationship between them, could be observed. For instance, in order to protect her husband from an emotional disturbance, and in order to maintain a calm atmosphere, many aborters, as we have observed, particularly amongst the habitual aborters, would not discuss her problems with him. Certainly, specific sensitivities of the spontaneous aborters may also cause misunderstanding between them and their physician, that they understand something entirely different what the physician has tried to convey to them. And these may cause considerable anxieties. And if this woman doesn't have opportunity to discuss it, then this misconception may operate in her like a time bomb. We have found that simple psychotherapeutic techniques can be most helpful to maintain a threatened pregnancy, and we have particularly found it helpful in habitual aborters. This technique consists of weekly sessions of 15 to 40 minutes duration, in which the patient is encouraged to discuss even her minor worries and doubts. Explanation of the anatomy and physiology of sex and pregnancy and childbirth seem to be reassuring. These patients should receive a permission to phone their physician even for minor problems and stresses, because they are very susceptible to anxiety, and anxiety seems to hit the target organs associated with pregnancy. Discussion with a husband alone, or more so with a patient, are helpful. This we have found to be a very helpful technique even in the hand of a non-psychiatrist. In fact, this is such a simple method that anybody who looks after a pregnant woman, particularly after spontaneous habitual abortion, should be able to carry on.
In the threatened or habitual aborter, besides giving her the support Dr. Weil suggests, Dr. Attlee, do you feel the use of hormones is of any value?
Well, I think it's pretty generally felt by those who have tried them that hormones are of no value whatsoever.
Now, Dr. Attlee, we come to a pet subject of yours. Is vomiting of pregnancy a psychiatric problem?
Well, I don't know whether it is a psychiatric problem entirely or not. I think that probably there's a certain amount of vomiting that occurs more or less apparently normally in pregnancy. And if we take two things into consideration, first of all, that so many women who are on the hormones vomit. Some people, for instance, can't take the pill because they become so nauseated. And then we consider that during pregnancy, a woman is just simply a hormone factory. Her blood's full of these hormones. It's possible that this normal, so-called normal vomiting in pregnancy is due to that. But when it becomes excessive, hyperemesis gravidarum so-called, then I think perhaps there's a psychiatric factor added. And a great many of these cases who have been examined by the psychiatrist, such a factor is found. In any case, what we do find is that psychiatric treatment is the most useful and most successful method of handling the situation.
Would you like to discuss your treatment briefly?
Well, briefly, the treatment is take away the vomit basin, take away the husband until the woman has stopped vomiting for 24 hours. Treat her only in hospital on your quarterdeck and you're not on hers. And feed her regularly and feed her every time she vomits.
Dr. Weil, I know you want to comment on that treatment.
From my observation, I can say, and I have seen many of these women treated in this manner, that this method is most successful in the hand of those who have utmost confidence in it. At times, hypnosis helps. In any case, I agree that the woman with hyperemesis should be isolated from the worrying, anxious, panicky relatives and provoking husband.
But isn't it true of every psychiatric undertaking that you undertake with regard to a patient that your confidence in it is the important thing? A psychiatrist with no confidence, to me, shouldn't be a psychiatrist.
That's quite true, but without wanting to get into a controversy about this subject, the woman with hyperemesis gravidarum at times can develop toxic symptoms, and one can carry this method a little far. And I don't think a psychiatrist alone should handle it without the cooperation with an obstetrician.
Dr. Attlee, would you mind giving us an example of a problem case that you have handled personally?
Well, I can think of one poor little woman. She was in the hospital several times, and what we elicited of her background was that she was married to a husband who had a mother fixation. And he and the mother had, from the time this girl became pregnant, kept harping on the fact that she could never have this baby. Now, putting her on our treatment that I've outlined, we could get her to stop vomiting in a matter of 3 or 4 days, which is about the usual length of time that it takes, or the average anyway. Then she'd go home, get back into the bad psychiatric situation again, and she'd start to vomit again. And I suppose of that pregnancy, she spent probably almost half of it in our hospital, All the time she was in hospital, she was free of vomiting for most of her stay, and as soon as she went home into this bad atmosphere, she would vomit again. That is the sort of case that you do run into.
Dr. Attlee, can I ask you again? I know you have organized a very extensive education childbirth program in this area. Do you feel its value is very great in lessening the psychological overtones of labor?
Well, let's put it this way. It certainly has lowered the decibel rate in the case rooms of our maternity hospital. In the old days, you go to the maternity hospital on any rampaging night, and the thing that struck you was the awful agony these women were in. They were complaining loudly, some of them were shouting, some of them were completely out of control. Now today we don't see that. It's a phenomenon that's almost passed away. There'll be the occasional woman, but we don't see it as frequently. And I think that one of the reasons for it is that the education for childbirth has prepared women, has removed so many of their fears about labor. Although they may be having the pain, it's not affecting them through fear as much as it would otherwise, because fear and pain sort of act on one another in a way that the fear plus the pain actually enhances the pain. And if you can relieve the fear, the anxiety, the pain becomes lessened. And to that extent, I think it has been very salutary. The other thing is this, that I think it has a good psychological effect, is that we try to create in the women who go through this program a feeling that they're doing something highly important, the one thing in the world that they can do that a man can't do. And that therefore we try to help them to get the greatest possible satisfaction from this. And we feel that this may play some part in lessening the number of women who trace some future illness back to a confinement. Some illness for which one can find no physical basis, but you feel was due to a psychological trauma of the pregnancy and the labor.
What do you feel a general practitioner can do in a small area to organize a program like this? Or
well,
how can he help his patient?
Sure. We started that same way. 2 or 3 of us started doing it ourselves, training the patients ourselves in our own office. But we very rapidly found that when we got trained nurses to do the same thing, that we got a far better result, because the women would bring their problems to the nurses where they would think that the doctor would think they were being foolish to bring a trivial fear to him.
And are your brochures you have available to all?
The brochures that we have are available to anybody who wants to write in for them. We charge a small price just to cover the cost of the mimeography.
What does this brochure consist of? What's the content?
Well, the brochure, we tried to make it as simple as we possibly could so anybody could read it. And it's a simple brochure that just tells what the thing is and what about the breathing exercises that they do during labor. And then there's a letter that more or less tells them what goes on inside them and what's going to happen and what they're to expect and so forth.
Now, Dr. Weil, why do you feel so many women trace various galaxies of symptoms for which no physical cause can be found to a pregnancy?
Most women today are only a few times in their lifespan pregnant, and even the normal pregnancy for some women is a traumatic experience. For instance, the pregnancy may not be wanted for rational or irrational reason. She may carry the child or may have carried the child of an undesired man. She may have become pregnant before she got married. Many women have a number of diverse misconceptions regarding pregnancy, and not a few have irrational fears of childbirth. Some of these false notions are so bizarre that the women do not even dare to verbalize them, or they feel they are so foolish that they don't even dare to mention them, and therefore it is on the physician to find out what really goes on in this woman's mind and what they thought about their pregnancy they blame for their present symptoms. Another source of conflict regarding pregnancy and childbirth stems from impersonal management on the part of the physician and the other staff in the maternity ward. And here I would like to stress and emphasize and underline what Dr. Utley has said. What goes on around the pregnant and parturient woman at the time of childbirth is most important. The attitude of rigid sterility seems to penetrate even into interpersonal relationships of this ward, and while everything is sterile, the personality, the problems of the woman in childbirth is completely neglected. Any symptom of anxiety or depression or any physical discomfort that sometimes after pregnancy, and sometimes even years after, and I hear about them in my psychiatric practice, are blamed on past pregnancies and childbirth rather than on presently existing physical or emotional disturbances. It is a lot easier to blame a pregnancy than the husband who drinks. Such associations of present complaints with past pregnancies are definite indication for further psychiatric inquiry, especially if the complaints focus around any pelvic organ. And again, psychiatric consultation in resistant cases and treatment may be indicated.
One of the most distressing periods in many women's lives is the menopause. Dr. Weil, how would you define the menopause?
The menopause, in my mind, is a period of normal transition from the age of potential childbearing to the remaining span of life of a woman when pregnancy is not anymore possible. This is a period in which the woman has to make a number of adjustments and in which frequently psychophysiological and purely psychological disturbances occur. The menstruation ceases, of course, but the psychological response to the cessation of menstruation are abnormally distorted by all kinds of conflicts and myths, such as termination of sexual drive. Many women feel that when menstruation ceases, the sexual desire comes to its end. Or the idea is that the menopause is always followed or accompanied by emotional upheavals. Woman feels maybe that she is not anymore attractive to her husband or to other men. The family is often shrinking at this time, children leave, parents are left to themselves, there's more freedom, new orientation to life is necessary. This is also the time when women begin to re-evaluate the past and have second thoughts about their mistakes and omissions. All the problems of the past which existed in the early sexual life, during her married life, and during her marriage are reactivated, and very often fears for the future dominate the picture. But for a normal person, a normal woman who had no particular conflicts and who was psychologically healthy, the menopause is a normal change that is accepted by many casually, and some even appreciate the fact that they can't become pregnant anymore and enjoy the freedom.
Now, Dr. Atlee, would you like to discuss the gynecological problems of the menopause?
Well, the main gynecological problem that comes to us is the hot flushes. They sometimes are minimal. Some women don't have them at all, and some women have them very, very badly and are very embarrassed by them because they think that their face is flaming red, and when they're out in company they think that everybody knows what's happening, and that embarrasses them, upsets them, some people quite badly. They get quite emotional about it. Very often you can see they're having a flush, but their face isn't flaming at all, and I think it often helps to tell them that. But by and large it boils down to some form of hormonal treatment. Now, women who are on the pill probably will find that they don't suffer particularly from hot flushes because there's enough of the estrogenic hormone in the pill to control them. But for the woman who is not, then it may be necessary to give her some form of estrogen. Now, I think a warning point I might raise is the question of dosage. A great many women have prescribed for them, say, silbestrol, 5 milligrams once a day or twice a day, with no direction as to how long they're to take them or when they're to stop or anything like that. My own policy is to give them a small dosage, 1 milligram of silbestrol, and say if after 4 days the hot flashes haven't stopped, double the dosage and go on doubling the dosage until they stop. And then when the flashes have stopped, cut the dose down until you find a maintaining dose, which will vary from woman to woman. And you may find that 1 tablet a day will be enough, 1 tablet twice a week, or 1 tablet even a week will be enough. And then I think it's a good idea to say, well, at the end of 6 months, you better stop and see what happens. Some women find they will go along for months, and then they'll have some sort of an emotional upset, and the flashes will come back. Well, they can very easily be controlled. But I think that it's a mistake to give a woman a hormone, let her go on taking it forever without any warning that she perhaps ought to cut it down or cut it out after a certain length of time.
Dr. Weil, what do you feel is the best way to deal with a woman having menopausal symptoms?
Many women in this period have all kind of emotional difficulties for reasons I mentioned before. They run from minor tensions and anxieties to pains, to mild depressions, to severe psychotic illnesses, which are frequently associated with excessive restlessness, paranoid, and suicidal tendencies. The psychiatric management in the less severe cases of menopausal emotional disturbances, which can easily be handled by a general practitioner, should consist of the following principles. First of all, women with menopausal problems should receive an explanation of the physiology of the menopause and clarification of the many misconceptions which exist regarding this period of a woman's life. Secondly, give the woman the permission, indeed encourage her to discuss her specific personal problems. It will take a little while before she will trust the physician to tell him all about the ideas, the conflicts, the problems in her present life situation and in the past. And of course, she would be more free to discuss them if she knows her physician better. Treat the tensions and anxiety with mild sedatives and tranquilizers, and depressions with antidepressant drugs. While hormonal substitution therapy may be helpful in alleviation of the symptoms of flushing and dizziness, they have no influence on the more severe emotional or on any emotional difficulties, unless the emotional difficulties are responses to flushing and dizziness. Psychotic disturbances in this period definitely require psychiatric treatment, and frequently treatment in an environment in which the woman can be supervised, particularly those women who have suicidal tendencies. Many women can hide their depressions very well and cover them up, and it is on the physician to find depth of their depression by psychiatric investigation and mental status investigation.
In summary, then, could we agree that every girl should get, somewhere in her education, a fairly thorough insight into her particular female physiology? We also feel that any girl who continues with severe dysmenorrhea despite adequate treatment into her 20s, and any woman who traces a set of symptoms for which no physical cause can be found to a previous pregnancy, and every woman who is more than usually depressed immediately after the birth of a baby or during menopause requires psychiatric help. And this would be better done too early than too late. I also think we can agree that it is important for the family physician to be acutely aware of the emotional problems that present at these 3 traumatic times in the life of a female. He or she should be looking for them constantly, and when suspicious, to stimulate zealously her discussion of them, and treat them himself or with psychiatric help to the best of his ability.